Start recording. All right. So as you're aware that the Implicit Network has a desire to see more pediatric sites take on and implement the implicit ICC model of care, which we are hoping will allow us to serve and provide care for more mothers and birthing persons, babies and families. So with that in mind, our topic for today's webinar is going to be focusing on ICC implementation at pediatric sites. The webinar will be presented by two passionate pediatricians who have been involved with implementing implicit ICC at pediatric sites. So I would like to welcome Dr. Sarah Jones, who is a physician champion at the University of Mississippi and is an active member of Implicit Network since 2016, and continuing those efforts there. And Dr. Emily Scott from Indiana University of Health Methodist Hospital. And although she's not officially a member of the Implicit Network, she has been more recently involved with implementing ICC at multiple pediatric sites in Indiana. So with those very, very brief introductions, let me go ahead and give the floor to Drs. Rohn and Scott. And we're excited to hear what they have to share about this.
Okay, so I guess we will start with our slide presentation about doing implicit interconception care in the pediatric setting. We will be going over our two different experiences and sites and how it has been in pediatrics. So next slide. Neither of us have any sort of disclosures. Next slide. And we have our own acknowledgements. We have had both support from the March of Dimes in our respective states. Dr. Scott has had Riley Children's Foundation, and I have had the Mississippi State Department of Health with the March of Dimes help with some of the financial support for starting the implicit project. Next slide. So generally in the overview, there's kind of very little information that exists about doing interconception care in the pediatric setting, particularly the pediatric wellness setting. We do have some courtesy of the Implicit Network through the Family Medicine Education Consortium for the family medicine, for our family medicine partners, and through Implicit, which we screen for maternal smoking, family planning, preconception, folic acid, multivitamin supplementation, and maternal depression, with the goals to decrease preterm and low birth weight infants. And as stated, the findings and data with Implicit thus far have been limited to family medicine in the northeastern United States. But pediatrics is a really good and very important access point for maternal screening, as Maha said, interested in trying to expand into more pediatric sites because Implicit can be used in pediatrics to perform intrapartum care and interconception care. Next slide. So just some general backgrounds about Implicit. Strategies to improve pregnancy outcomes have previously focused largely on prenatal care, but it's really had minimal outcomes, impact on the outcomes for preterm and low birth weight infants. So therefore, people have looked at, well, maybe we should, prenatal care should really become a longitudinal part of a woman's health. But because by the time you go into prenatal care, it's often too late to affect some of the early birth outcomes, and preconception care would obviously be ideal, but most pregnancies are not planned and only a very small percentage of women actually have a preconception visit. The CDC in 2006 recommended the risk assessment and intervention in the interconception period, and it became a healthy people goal for 2020, and portions of it are part of the healthy people goals in 2030. Next slide. So I'm gonna let Dr. Scott take on her slides.
So I believe probably everyone attending this webinar is aware of what interconception care is, the care of a woman in between pregnancies from the birth of one child to the conception of the next. And as Dr. Jones said, it can have a really tremendous impact on subsequent pregnancy and birth outcomes. What we also find is a time when women don't really focus on their own health. During pregnancy, a woman usually attends her prenatal visits, and the families really focus on making sure the mom gets the health and support she needs. But often after the baby's born, the family's focus shifts from the care of mom to the care of baby. And so a lot of women will go without their own checkups, but definitely make the checkups of their children. We also know that access to interconception care is impacted by racial disparities as well. And it's an active area of interest, as Dr. Jones said, with the CDC's preconception care work group, which was founded in 2006. Go on to the next slide. And these are the top 10 preconception health indicators that the CDC identified. The ones I've starred are the ones that we touch with IMPLICIT, the current smoking, depression, folic acid intake, and then appropriate birth spacing. A lot of these points Dr. Jones already made. We know that interconception care is important because almost half of pregnancies in the US are unintended, not necessarily unwanted, but maybe mistimed. Only about 23% of women actually report receiving preconception care. And I actually think that number sounds a little bit high to me. By the time a woman begins prenatal care, it's often too late to modify those risk factors that are associated with poor birth outcomes. And women may revert to behaviors that they stopped during their pregnancy, like smoking or substance use, and go back to using tobacco or cigarettes again once their baby is delivered. So this is a really a good time to kind of reinforce those messages of wellness with women. Next slide.
So again, we've already mentioned a bit. So IMPLICIT is this framework that we can use and through the network, which is a collaboration of academic family medicine providers that uses these tools to perform interconception care. And it involves, assessing all those risk factors that Dr. Scott has mentioned, and it seeks to overcome the barriers of maternal care by meeting these high-risk mothers where they are at well children visits. Next slide.
So the nice thing about IMPLICIT is that it targets women at their child's well child visits. The screenings are all brief and easy to perform within the context of a pediatric visit, and it really just enhances healthcare for women who may not otherwise seek care. We talked about this already. We know that, moms will attend their child's well child visits. 92% of women attend with their child, and 93% of women are actually willing to receive health advice from the child's doctor. So women are willing to get their care this way. We also know that pediatric providers providing well child care, either within pediatric clinics or family medicine clinics, actually see babies so frequently. I mean, up to 8 times if you're, following the AAP's Bright Future guidelines. And so that's 8 access points for women that they wouldn't otherwise have. A lot of times when we first start talking about this in pediatrics, what has come up when I've tried to pitch this to different offices is this within the scope of pediatrics. We know that actually 2 of the things are things that pediatricians should be doing anyway. So pediatricians should be talking to families about their tobacco use. That's covered in the AAP's policy statement on protecting children from tobacco, nicotine, and tobacco smoke. And so that should be a focus of pediatric well child visits. In addition, the AAP endorses screening of women for postpartum mood disorder during those pediatric visits in the first month of life. So 2 of these things are things that we should be already doing.
Next slide. And again, there was a study in the Journal of Pediatric Healthcare that said 85% of mothers found it completely acceptable to discuss their health, including depression, smoking, alcohol use at the pediatric visit specifically. And as stated, there's some of these parts we are supposed to be screening anyway. It shouldn't be a foreign concept. Next slide.
So I'm going to talk to you guys about how we've implemented IMPLICIT in Indiana outside of the network. So we're going to give you a kind of exposure of what it's been like outside of the network versus Dr. Jones's experience inside the network. So we implemented IMPLICIT. We've done 2 quality improvement learning collaborative cycles over the past couple years. And so if you want to go to the next slide, I'll talk through some of the challenges and success we've had in Indiana. So one big thing that we did a little bit differently is when we look at infant mortality in Indiana, this is kind of our breakdown in terms of what we're seeing our infants die from. And this is our 2019 data. And so we see a good chunk of kiddos, babies dying from perinatal risk, prematurity, low birth weight, and congenital anomalies. But we have a really significant contribution to our infant mortality rate from SUIDs or SIDS. Go ahead, go on to the next slide. And it actually rises every year here in Indiana, and it's greatly impacted by racial disparities, with our Black infants dying at about 2.5 times the rate of our white infants from SUIDs. So one thing that we felt very important to add on is we were trying to get practices engaged in the idea of doing the IMPLICIT program, with the idea that this was going to help Indiana with our infant mortality rate, was we added a safe sleep component to that. So if you want to go on to the next slide, Maha. So with IMPLICIT, we obviously are focusing on screening women for interconception care from birth to 24 months of age. We added an additional screen to IMPLICIT, which was a safe sleep screen, and really screening families for ensuring that they have a safe place for their baby to sleep, and safe sleep practices at both bedtime and nap time, because we have seen in Indiana that about 40% of our SUIDS deaths are actually occurring during nap time. And so that was a question that we added on to our IMPLICIT screen from birth to 12 months of age. And so that was, and then they would do so they would actually do 5 screens through IMPLICIT from birth to 12 months of age, and then they would do 4 screens from 12 to 24 months of age. You want to go ahead? So we initially, our First Learning Collaborative had 2 pediatric clinics within Indianapolis. One was a public health department clinic in Marion County, had a pediatrician, a family medicine physician, and a family medicine nurse practitioner. They had social work on site, and they actually had an OBGYN on site as well, which was very helpful when we started doing birth spacing screening. And then our second clinic was a general peds subspecialty clinic that focused on infant growth and development, and mainly served NICU graduates. And this was staffed by 2 pediatricians, and there was a social worker embedded in clinic as well. I'm going to go forward. So we started in January 2019. We had a big afternoon kickoff session, and we really focused on the why behind the project. So we talked about infant mortality in Indiana, how pediatricians could help outside of just talking about safe sleep practices. We introduced them to the idea behind interconception care and the IMPLICIT model, and then did a lot of training on quality improvement and did process map development. And then following the kickoff session, a multidisciplinary team from both sites met monthly at 8 monthly webinars, where we did data review, shared our current PDSA cycles, went through some QI teaching, and then a review of best practices as well. Go ahead. This was our key driver diagram that we developed, and we'll send these slides out, I'm sure, make them available so that you guys can review this if that's something that you're interested in, but really was just helping us identify what we needed to be successful, which was having processes in place for screening, for identification of eligible patients, screening, counseling, and then making sure we were following up our positive referrals appropriately, or positive screens appropriately. Go ahead. We also, through our funding from March of Dimes, we were able to identify an infant mortality champion within each clinical setting. And we wanted somebody very close to patient care. So in our sites, we had either a nurse or a MA or a licensed practical nurse who were responsible at the site for leading the work of IMPLICIT. They met with myself and our QI coach weekly, and we developed PDSA cycles every week. They were also responsible for communicating with the clinic team and collecting and entering data in the database. And we supported about 1 half day a week of their salary to implement this and to work with us. Go ahead. So this is just an example of what the project looked like in one of our clinics. It looked very similar in the other one. And so we did a phased implementation where we had the clinics pick what they wanted to start with and then move forward kind of depending on how they did. And so you can see this was actually just screening. So kind of how they did is they phased in the different aspects of the program. Go forward. And then this was kind of our overall project run chart, if you will. And so we knew that not every family would qualify for all 5 screens, because we were screening obviously babies from 12 to 24 months who didn't need safe sleep screening. And so we looked specifically at eligible encounters that had 4 or more screens performed. And so you can see that over time, as we phased things in, we were able to get by the end of the project to about 90% of all screens being performed. Go forward. So what was a positive screen? I think this is probably pretty self-explanatory, but anybody who reported their baby wasn't sleeping safely at bedtime or nap time, if mom was using cigarettes or vaping, mom wasn't taking multivitamin with folic acid, if mom didn't desire pregnancy in the next year and was not using a reliable form of birth control, or if a mom had a positive score on the PHQ-9 or Edinburgh. And both of our clinics actually picked a different depression screener to use. So we let them choose which one made the most sense for their patient population. Go ahead and go forward. And so with positive screens, what we found in our clinic sites is we were picking up a lot more moms who weren't using folic acid, or who expressed the desire to not have another pregnancy within the next year, but were not using a reliable form of birth control. We picked up some moms with depression. We see some safe sleep challenges. We had very few women smoking in our population. Forward. And so this was the percentage of time that we were able to document that we provided an intervention with a positive screen. And I think not surprisingly, we were a little bit better at the things that we typically think of as being within the realm of a pediatric care. So we were better at providing safe sleep interventions or documenting that we responded appropriately to a positive Edinburgh or a PHQ-9. We weren't as awesome at reporting that we provided interventions to those areas that I think our pediatric providers were a little bit more uncomfortable with, like the folic acid and the birth spacing screening. Move forward. So what made this feasible in our practice, and I'm going to go through these a little bit slower, but we did a lot of modifications and adaptations to the IMPLICIT toolkit that is on the website, just to make this a little bit to fit better into the settings that we were working in. So I'm going to go ahead and have you move forward, and I'll go through these a little bit slower. One was that I worked really hard on trying to develop a one-page sheet for screening that we were going to collect data on. And we presented it to the clinics, and their heads about exploded. And they were like, oh my gosh, we cannot do that. This is not something that we can do. And so we immediately backed off. And if you want to move forward, we kind of fell back on that QI, old QI saying is you don't want to boil the ocean. So if you want to make a big change, which we wanted to make a big change, you're not going to start by putting a lighter under the ocean. You are going to go ahead and just, boil a cup of water at a time. And then over time, you're going to gradually get a change, but you're not going to expect a big change all at once. So go ahead, you're fine. So we really focused, we talked to the team, we used the phrase baby steps. And so we said, we're going to move forward in baby steps. We are going to pick our low hanging fruit, what seems like an easy win for next week. And then we're going to move forward that way. And then once we did that, we got a lot more buy-in from our clinics, and they were like, okay, yes, we can screen for safe sleep. And then, next month we can add something else on, but they felt very overwhelmed with the thought of doing it all at once. Go ahead and move forward. We use QI methodology to guide our steps. So we set SMART aims, and we made sure our SMART aims weren't to have 100% screen because we knew that wasn't going to be feasible. Our project overall, I set the bar pretty low. When I set my SMART aim, I was like, well, I want to get 50% because 50% is better than 0, which is where we were at. But the clinics always wanted to set it a little bit higher. So we, usually set aims at about 70%. If you want to move forward, and we use PDSA cycles to guide our steps. And I will go through an example of one of those. Go ahead and move forward. So if our aim was to screen 50% of mothers for tobacco use by the end of the next week, we kind of decided, okay, how was that going to be done? Was it going to be done using a prompt in the EMR while rooming the baby? We performed the screen for a week. So we did do weekly data collection and weekly PDSA cycles, and then looked at that data and then decided whether we were going to adapt, or abandon the change. So in this case, using that prompt, we exceeded our goal of 50%. And so we decided we adopted that particular change. Go forward. We also expanded our eligible visits to include problem-focused visits. And I think this was partially due to our patient population. We had a lot of families that would come in for a sick visit, and then they'd realize that they hadn't had their well child done. And so then it would convert to a well child visit. And it was a little bit, I think, hard for the people rooming the patients to know whether it was like an implicit eligible screen or not. And so we ended up just deciding, like, anytime they came in, if they were under 24 months of age, they were going to get a screen done. And that really helped us, I think, streamline the workflow in the clinics that we worked in. Go ahead and move forward. Oh my gosh, the birth spacing piece was so tricky. And I think that was the big piece that we really got a lot of like deer in headlights looks, or people like, oh, everyone left this one for last. And so we talked through that quite a bit. And one clinic in particular, the clinic that saw NICU grads mostly, they were really worried about offending the mamas by asking about their birth spacing plans and talking about interpregnancy intervals, because they didn't want the moms to feel like they were blaming them or that they didn't want them to have another baby. And so we had lots and lots of conversations around this. We took this to our hospital's patient advisory committee and worked through wording. And we ended up deciding to use something called the PATH framework, which I'm not sure if you guys are familiar with. I put the link down here, but the PATH framework, we decided just made the scripting really nice and seemed more conversational. At first, we were trying to use one key question, but we ended up using the PATH framework, and that is parenting or pregnancy attitude timing, and then how important is what it stands for. So the question is, do you think you might want to have more children at some point? When do you think that might be? And then how important is it for you to prevent pregnancy until then? Because we were just finding we were having, a lot of families that were like, well, I don't really want another baby for a couple of years, but if I got pregnant now, it'd be fine. Like, I'm not like super committed to my 2-year plan. And so we really just wanted to respect moms' desire while providing them with the appropriate information about what that desired interpregnancy interval is, and making sure they met whatever their own family planning goals were. So if you want to move forward, we actually ended up asking permission from a lot of the moms, or from the moms in the infant growth and development clinic, before we asked the birth spacing questions. And we worked on the scripting quite a bit, but we ended up saying something like, we are interested in improving health outcomes for your family. We asked questions about your plans to grow your family. Is it okay if we ask these questions today, or would you prefer that we skip this section? We rarely had moms saying that they didn't want to talk about it, but I think this phrasing actually just made our pediatricians feel better about asking the question, that they kind of gave the mom an out if she didn't want to talk about it. Move forward. And then just a lot of, and I'm sure Dr. Jones will talk about this too, it's just a lot of resource planning. So making sure that, I think always the biggest challenge when we implement screening is people are like, it's not so much the question asking, but everyone's just really afraid of what's going to happen if they get a positive screen and what they're going to do. And so we just made sure we had really robust referral pathways, something easy for them to do. So our Indiana Tobacco Quit line, we have the ability to just send an electronic ding to them with the parents' information and their name, and they'll reach back out to them. So we just wanted to make everything as easy as possible. Move forward. So in 2020, we got additional funding from March of Dimes, Indiana, and we wanted to kind of see if we could expand this out of kind of a traditional clinic setting, just to kind of see if is this going to work. So we and it ended up working well with COVID starting because the hospital didn't shut down. So we were able to go into the NICU and actually do this quality improvement project during COVID. And then we also worked in a pediatric subspecialty clinic, which was a sickle cell disorder clinic as well. So if you move forward, I'm just going to give you a little bit of information about our NICU, because we obviously had to make additional modifications there. So we are supporting the time of 2 social workers who are infant mortality champions. We had to decide, who we wanted to screen within the NICU population. And so we ultimately decided to start with the screening of moms of infants born at less than 35 weeks, thinking that these moms would be the highest risk for having a repeat low birth weight or preterm delivery. We had to think about timing. So we wanted to kind of mirror well child visits as much as possible while they were in the hospital. And so we did the initial screen at 2 weeks of life, and then every 4 weeks thereafter while they were in the NICU. And then because of COVID, we were actually had to switch to doing some of the screening via telephone or virtual visit versus screening in person. So that was a new challenge for us to work through as well. If you want to move forward. So this is what this has looked like for us so far. So we're done in June. And so month 7 is actually March. So I don't have our April data done quite yet, but you can see that we've been, adding in, kind of phased in just like we did before, since, and we're working through this and talking now about sustainability planning for this. Do the same thing, asking maternal permission before we ask the birth spacing questions. They felt like that was very important in the NICU setting in particular. I'm gonna move forward. And we're picking up a lot of kind of the same things that we saw at our last visit, just a lot of moms not taking folic acid, more than I thought, actually, seeing as they literally had just had a baby. We're seeing about 40% of moms not taking folic acid, 40% of moms without a well-defined birth spacing plan to meet what they state their family planning needs are. And about 20% of moms are being identified with maternal depression, which is a little bit higher than we saw last time. It kind of makes sense with where their babies are at. So if you want to move forward, I think what's made us successful, like what this big success has been in terms of getting people engaged and keeping the projects moving forward, is focusing on the why. So we really always tie this back to every opportunity that you're doing implicit is a chance to save a baby's life. And to, our state has a really poor infant mortality rate. We have traditionally been in the lower 10, bottom 10 in the US for the past decades and decades and decades. So, we have a lot of awareness here in Indiana around infant mortality. And I think this was a cool way for us to engage pediatricians in a way they haven't been engaged before. And we had a lot of excitement around that. You want to move forward. This is our Labor of Love conference, which we have every year in Indiana. And they actually put up socks to represent all the babies that died in Indiana before their first birthday. And so this is a really I think stark visual that that a lot of our faculty and pediatricians have seen. And so we would kind of come back to this and make sure they understood that kind of supporting maternal infant health is something that's up to all of us. So I'm going to turn it over to Dr. Jones and she'll talk through her experience.
All right, so now we're going to quickly go through the implementation of implicit in an academic setting within the network. Next slide. So the University of Mississippi Medical Center is part of the implicit network. We have been since 2016, and we have regular calls and assessments of our data with the National Center to help support local concerns for data and offering support. But then we also have twice-a-year meetings with the entire group. And this, of course, due to COVID, it's been a little virtual, but it's amazing, that we all meet and get together and look at the greater project together, looking at billing, EHR concerns, and project plans as part of the continuous quality improvement model. Being in this group, being a pediatrician surrounded by family medicine, it's actually a unique perspective to be able to see the family medicine side of it. And it helps, it's always, at least personally, helped me with the awareness of kind of emerging principles in maternal health, such as the fourth trimester. And never mind the fact they are excellent people, very, engaged in the program, but also just really excellent people to work with. And in general, pediatrics and family medicine providers, we are a team. We're a team for maternal health. And I think in general, in pediatrics, we are learning to take a little bit more responsibility for that piece of maternal care because it does affect the child heavily and the family health. Next slide. So we implemented the program at 2 pediatric clinic sites at the university, the only 2 that we had at the time, at the Jackson Medical Mall and the North Clinic. These are off of the main campus and in the community. We have about 10 attendings and about 47 residents per year that were trained or retrained on the process. Our first screen for phase 2 started on 3/22/2017, and we started phase 3 on 6/30/2019. We had to change a little bit of how we collected our data, and we collect it directly in REDCap now, but next slide. So pediatric providers, both residents and attending physicians at both the sites, were initially educated on the project through a grand rounds, introduced to the screening tools and action plans, and given those resources and information. And then as we were building up to actually implementing it, we would send out in several emails and just speak among ourselves about it, from attending to attending and also attending to residents as we started the implementation. And as we implemented, the data would come monthly through an EPIC report, and I'd look at it and kind of notice any patterns or issues and take those to the individual providers or just the group in general to try to modify any behavioral concerns or encourage participation and clarify the use of the actual screen. Next slide. So the attending physicians, of course, during resident clinic are continually teaching the residents, because part of when they come sign out to us, we ask about everything. We ask about, well, how is the implicit screen? What about mom? And we reinforce the usage of the screen and educating mom and helping with getting the resources together for mom. We would do annual and continue to do annual presentations of the de-identified data to the main group, so everybody can get a feel for where we are as a population and also where we are as providers and doing the actual screening. To help encourage the providers to participate, I offered maintenance of certification credit from 6-1 to 12-1. We did a specific, like I guess you say, mini project within, and they gave maintenance of certification credit for it. Next slide. So, and of course, I'm not going to go into this in detail, but this is just kind of the flow of our intervention in the pediatric setting, which also kind of highlights as well the big difference between the pediatric and the family medicine portion is we are not the provider for the mother. So sometimes that can make things a little bit difficult to follow up like through the maternal chart because I don't have the mother's chart. Or they may not be part of the university system, so I can't go in her chart. But anyway, so very similarly, we use the ACT Center, the 1-800-QUIT-NOW for smoking, contraception practices. We direct them towards a provider and dependent upon their age, whether they could go to an adolescent provider, which we can set up for them, or sending them to a provider within the university system, or giving them information about one outside of the system, or if they have to use a federally qualified healthcare center, because there's so many barriers, like if they don't have insurance or whatnot, that we have to try to help direct them in the right direction. And then of course, with the folic acid and multivitamin supplementation, just kind of recommending it. And just one thing, a lot of times some of the moms they're like, well, I don't have any of my prenatals anymore from when I went to, when I was pregnant. It's like, well, that's okay. You can go to the store. And I know that sounds kind of funny, but some of the moms don't like to swallow those pills or whatnot. So I'm like, you actually, they make the chewables, the hard chewables that are meant for children that taste good. There's adult dosing on the back of those packages too. And a lot of moms that are really resistant to the vitamins, like, oh, really? Because like, that sounds like I could do that. And then because I have other kids in the house, I just buy a big thing and here's some for you and for me. Next slide. That again, I know this is a lot in one thing. It's just how we would respond to elevated depression scores. So if a PHQ 9 is less than 10, mother may be at risk and have concerns. And again, directing them to providers dependent upon their insurance status and what is available. Of course, we have, PSI International, we have some other groups also, mom.me and some other things here in Mississippi. But if they have a PHQ greater than 10 and they're very high risk, particularly if they identify any suicidal ideations, then we have to step in and, get her the mom immediately to the ER and try to make sure that the child is safe, the mother is safe, and the family is safe. It doesn't happen often. It has happened, at least that I'm aware of, between the two clinics once or twice where we really have had a actively suicidal mother. And so, but it's very important to act upon that. Next slide. So we're going to look more so at and focus on the provider behaviors portion of doing the screening. And not as much on our specific population responses. Our responses are very similar to Dr. Scott's, and actually nationally, our responses for smoking and contraception practices and whatnot in Mississippi are very similar with the nation. But ironically, we're at the very bottom of the stack when it comes to anything positive for maternal health, infant health, and whatnot. So I guess just briefly demographic wise, our patient during this study period, we had about 1,883 dyads that had 4,155 encounters. The mean age of our moms is 25 with high school education and 2 children. 80% of our population is African-American, about 18% is white, and about 2% are Hispanic. And then we have a few other smaller representations, such as the Asian populations and whatnot. So over the time period, so visits over the first 2 years of life, we kind of put them into the collections of when they could happen. So the percentage of initiated screens actually precipitously decreased from the very first visit, the 2-week visit. And I should say, yes, you should have a 2 to 3 day visit. Most of the time that's done actually in our newborn nursery here. So that's why we don't have it in the pediatric, general pediatric office. But you see it precipitously, we just did less and less screening out of the percentage of encounters. But also on the flip side, which is not represented by this graph, we actually had less and less of the parents coming to visits too, but this is a representative of the percentage of initiated screens for the well child check. Next slide. So in general, when it comes to interventions for multivitamin folic acid supplementation at our particular site, those who needed intervention got an intervention most all the time, got directed towards resources and whatnot. Whether it's visit 1 or this is just looking at the first year life to visit 5. Next slide. Smoking intervention, again, should be a very, very common thing because we've been doing this forever. We didn't do quite as well, but still not horrible. 75% or more got appropriate intervention for smoking. Next slide. Contraception intervention, similarly, as Dr. Scott mentioned, we pediatricians generally are not so super comfortable with the idea of trying to counsel a mom on using contraception, but they also need to, if you just think about it, we talk about such things with our adolescents too. So it's a little bit different, but not too foreign. So contraception intervention, though, if you can see, the intervention kind of declined as we got towards the end of the first year of life. Next slide. Oh, now the depression part. I think there was a little bit of, this is from phase 2 data. So there was, I think, some confusion a little bit about when we intervene and when we don't intervene. It's obvious if someone has, suicidal ideations or a PHQ-9 greater than or equal to 10 that they need an intervention, but our data did not show such. So we did not do the greatest job. And the other portion of it is the population was very small. We didn't have that many, the percentage of mothers who had a PHQ total score of greater than 9 was not that large. So, but we didn't do a great job either documenting our intervention or doing our intervention in those more critical periods. Next slide. And it looks even more dreadful when it comes to if they had suicidal ideation or whatnot. We did great jobs sometimes, and if we had 1 or 2, then, but even 1 missed is completely unacceptable. I'm just hoping in general this was all just related to inappropriate documentation on the screener. But again, next slide. And again, if someone was not in the high risk category, again, we should still have directed them towards, hey, these are some resources if you need them. Again, we did not give as much intervention for the lower PHQ scores, but again, it's a growing place to grow on, but there are also some documentation issues, I think, involved with that too. Next slide. So just kind of looking at these encounters of the attendings versus the residents and how the adoption and actual use of the screen over just initiating screens over phase 2. So the solid lines are the residents, the dotted lines are the attendings, the blue lines are the medical mall location, and the red lines are the North Clinic location. So these are just wellness encounter type, and being able to, as you'll see, the pattern of the attendings have decreasing amounts of new young babies in their wellness encounter population, because our kids we hold on to much longer, and they're older. They tend to be percentage-wise older, whereas the residents, we try to give them babies to follow with continuity of care. Of course, they have some older children, but they tend to overall actually have the bulk of the target population within their clinic. And that was true for both locations. Next slide. So how good are we at actually screening, though? We can tell that the medical mall location had a much more robust adoption. That's partially, I'm there and one other physician was there that are just, we tend to be, personality-wise, tend to like change and adoption more than probably average. But you can see, though we still didn't do as well as our residents, and that was the same also for North Clinic. The little the vertical lines, though, indicate the maintenance of certification period, and you'll see the motivation of maintenance of certification definitely helped at our med mal sites, and it helped too also at the North Clinic site, because it also increased not only the attending but the residents, because the attendings were then so, encouraging the residents also. And even after the period was over, yes, there was a decline, but it was still better than it was prior. So I don't have the specific statistics done up yet for if it was significant. Eyeballing it, it seemed like it would be, but I don't have that yet. So next slide. So Dr. Scott and I would like to open it up for any questions, thoughts, concerns, or whatnot in relation to our presentation.
Thank you so much, Dr. Jones and Dr. Scott, for presenting that. Let me just look in chat and see if anybody had any questions listed there. No, so does anybody have any questions based on what was presented? Or if you're interested in implementing at your pediatric site, any questions related to that?
I just have a quick comment, and that is that this is an amazing amount of creativity and energy. And for someone who's been doing this a long time, it was really inspirational. I'm very excited that you've taken this concept, taken into a pediatric setting, come up with your own questions and discoveries. So my question would be, how much interest do you feel that there is in the general pediatric community in terms of picking up this concept and moving it into other pediatric settings?
I feel like for me, it was a lot more before COVID. And I felt like I actually had several other sites that wanted to come on to our latest learning collaborative that were big pediatric clinics. And then once COVID hit, it just became hard to think about it. And so, but I think that once we get over this, I mean, if we do, and things go back to normal, I think that, there is excitement around it. I think that pediatricians, if you're in general peds, you kind of feel stuck, like you want to help with infant mortality. We talk about it all the time, but like all you feel like you can talk about is safe sleep. And I think this gives us something else to focus on that I think is really meaningful. And so I think that there is the desire there. We have to make it easy for people to do it too, and figure out how to best kind of slide it into peds and give people the appropriate supports.
And I do feel overall like the culture of pediatrics is starting to understand the importance of the whole family unit and focusing not just on the baby, but the family, the mother and the family unit. There's another program that we're actually going to be implementing here that kind of fits in with it, called Dulce, from the Centers for the Study of Social Policy. There we go. Which basically kind of is, again, a step into that, doing even better family screening and having a family specialist to kind of help. So I think there's growing interest and movement in pediatrics to try to attend to the family a little bit as a unit for family health and therefore infant health.
Yeah, thank you. My name is Gene Bailey, and I appreciate everything you guys have presented. I'm thinking about bringing the implicit network we started here in family medicine over to our Department of Pediatrics. So I appreciate a lot of the pointers, do's and don'ts, and those sorts of things. I was just wondering, in looking at the culture of a practice and that, how do you use your social workers or other people to do some of the things that I think would speak more towards family and social situations? And then secondly, my next question is, how much added time did people feel this was in implementing this, and do they feel that that was a distraction?
I know, speaking from our site, time, of course, is always a big sticking point. We do not in the general pediatric setting have social workers at all. So it falls on the attendings and the residents. And we were doing the screenings ourselves. So we took, we have a kind of a sheet that has just kind of the general information about the screening and why we screen, kind of like if you're handing someone a research packet, and have the basic questions done. So again, I know that there's other screenings being done during the wellness visit, ASQs, MCHATs and whatnot, and we're screening everybody upside and down the other. But it was helpful just to have them at least get the initial portions down. So if they needed a full PHQ-9 or something, we could just, you know, run into that. It really, it takes a couple more minutes, but again, some of these things we are already supposed to be asking anyway. It does expand the duration because the maternal depression is at least it's paid for from 0 to 6 months, where we're doing it through, you know, 2 years. But and of course, yes, time is what everybody is about very much, but you can make it efficient. And we have the documentation. It was, again, like I said, directly in Epic, but now I had to do it into REDCap. So I have a link that's now in the screening tab in Epic. You just click it, it opens up to REDCap and you put it in. It's a little bit more of a pain in the butt than when it was just plain Epic, but that's my institution. So. And
I think the feedback I got was very different based on the site. So one of our sites, we didn't specify who had to do the screening. We just wanted it done by somebody during the visit. And so the site that actually had the MA and the nurse doing the screening when they roomed the patient, they were just asking the questions as they were weighing and doing measurements, and they felt like it didn't add any extra time to their workflow. The site that wanted pediatrician to do it or a social worker to do it, they felt like it maybe added a couple minutes, which some days was a big deal and some days wasn't a big deal at all. So I think it just depends on.
Yeah, I was thinking more of the social worker with intervention. You know, we all screen, but
Yeah,
if you screen for the sake of screening, then why screen at all?
exactly.
There's information to have, but what do we do with that information? And so I was just wondering about getting more ancillary people involved so that they can do the follow-up or look at issues and stuff like that.
All of our interventions were done by our social workers. So we had social workers on all sites, and that's who did the interventions, at least for the postpartum depression and you know, safe sleep if they needed a crib or something like that. The folic acid, they would, you know, our providers would talk through it with them. But yeah, we utilize our social workers quite a bit.
yeah, and so with us, because we did not have a social worker, and that's why, and the provider was doing the screen. So as we were doing the screen, we were counseling, and then we would give them the resources. But following back up on, did mom access those resources, is a big issue, because we would just have to ask at the next visit, hey, you know, did you see them? Did you get this? And that's where I'm trying to get, because everything's always a financial concern related and barrier. I'm trying to get with the Dulce, trying to get, we'll have a family specialist who then can follow up with all these families, like trying to get something that's kind of like a social worker going.
Thank you very much.
Hi, this is Rachel. I am supporting the 2 clinics in Minnesota who are just getting started, and they are smaller family clinics, not affiliated with universities. And so I was curious, Dr. Scott, when you were talking about the QI work and how you were looking at that data weekly and like deciding what to do next. And when I heard that, I was like, wow, that's super frequent, like weekly. But then did your 0.1 FTE like support in that QI work, and like how is that? What was that process of like? Were you meeting weekly with the QI team and analyzing data? Could you talk a little bit more about that process?
Yeah, so we were lucky to have a lot of support. So we had funding from the March of Dimes that went to supporting the 0.1 FTE for the infant mortality clinic champion. And then I had separate funding from Riley Children's Foundation for this to be a project that I wanted to do. So I had some time bought out to do it as well. So I would meet with them and a QI co. We just had a standing meeting every Tuesday afternoon, and we would all meet together and go over their data. So we had them enter their data in, and we had used RedCap as well by Friday afternoon. Then I would have some time to look at the data over the weekend, and then I would meet with them on Tuesday, show them their data back, and then we would come up with our PDSA cycles from there. So I felt like it did fit in with the timing we had, but we were incredibly lucky to have a lot of funding to do that, because it's time more than anything. The nice thing about this project doesn't need stuff, but to do it, it needs time to think through everything.
Thank you.
You're welcome.
Right. Any other questions, comments?
I really appreciate the fact that you were asking patients permission to explore, for example, in the area of family planning. And I think it is very possible sometimes just to blurt it out in a way that may come across as being judgmental or from a power position. So that's very, very thoughtful and thought-provoking.
Did a lot of role playing, and I will tell you, the Patient Family Advocacy Council was integral in kind of helping come up with the scripting as well. So definitely that patient engagement piece was key. We just, wanted to make sure we were being sensitive to everybody, since we were taking it into especially a population that had been impacted by prematurity and congenital defects before.
All right. If nobody has any other questions, we can go ahead and jump off. I would like to thank Dr. Scott and Dr. Jones again for putting all the effort in and coming up with this presentation. And like I said, this will be available to anybody who would like more information. We will be sending it out via email. Slides will also be available. If you have any questions at any point during about the presentation or anything related to it, please reach out and I can forward those questions to Dr. Jones and Dr. Scott, and hopefully we can get some answers for you. So thank you again, and have a wonderful rest of the day.
Thank you guys so much.
Thank you.
Thank you.